Welcome, everybody. My name is Aaron Lisberg. I'm a thoracic oncologist at the University of California, Los Angeles. I'm really excited to join Research Practice today with Dr. Love to discuss key data sets from both World Lung as well as ESMO 2023. We're really focused on immunotherapeutic and other novel strategies for metastatic non-small cell and small cell lung cancer today. So we have a lot of data to cover, so let's get started. This is looking at durvalumab, again, an anti-PD agent plus tremelimumab, which is an anti-CTLA-4 plus chemotherapy in patients with frontline metastatic non-small cell lung cancer. This is the Poseidon study we've seen presented many times. And this is characterization of patients with PFS greater than a year. So what we can see here on the left-hand side are patients with PFS at least 12 months. And we can see, the clearest takeaway here is that the bar in red is clearly inferior to the two bars in differing colors of blue or purple, if we'll give us purple in the middle, where the percent of patients with PFS greater than 12 months getting chemotherapy alone was only 16.8%. And I would argue that the tremelimumab plus durvalumab plus chemotherapy is very similar to the durvalumab plus chemotherapy. They're very similar rates, but much higher. I mean, the takeaway here is that, again, the addition of anti-PD therapy at a minimum and potentially the additional addition of anti-CTLA-4 is beneficial to our patients. I think that overall from this presentation, there's two key takeaways. Got to give anti-PD agent, and the addition of tremelimumab to an anti-PD agent to chemotherapy, based on this data, I don't think is clearly warranted. This is a subgroup analysis for cemiplimab, which is an anti-PD agent for advanced non-small cell lung cancer patients. This is looking at the squamous subgroup analysis from the Empower Lung 1 and Lung 3 trials. And to put this in context, squamous disease is really defined in a different disease than non-squamous disease. We know that in terms of the types of chemotherapies we use. Of course, we use platinum backbones for both histologic subtypes, but the companion chemotherapy is entirely different. For instance, we know pemetrexed works well in non-squamous and does not work in squamous disease. And so as we look at some of these subgroups, it's important to understand, how squamous patients perform specifically. So that's what we're seeing here. Essentially what we're seeing are cemiplimab versus chemotherapy on the left-hand side on the Lung 1 trial, looking at the patients with a high PD-L1 expression. And then on the right-hand side, we're seeing cemiplimab plus chemotherapy versus placebo plus chemotherapy. Again, I don't think these trial designs are new in any way. I think they're very similar to what we've seen with other agents such as pembrolizumab and atezolizumab, but we are seeing a nice benefit in our squamous population. So let's look on the left-hand side. The hazard ratio for those PD-L1 high patients for overall survival is significantly better with cemiplimab compared to chemotherapy at 0.51. And for progression-free survival, again, we see a significant benefit to progression-free survival. Again, I'm using the term significant, but these are subgroup analyses. I guess I'm contextualizing that in terms of what I think is meaningful, and it is meaningful here. On the right-hand side, again, the squamous patients clearly are outperforming when they get cemiplimab plus chemotherapy compared to placebo plus chemotherapy. Again, the right-hand side, again, reinforces some of what we've seen, and we did see, in the first data set today that those negative patients benefit from the addition of the anti-PD therapy. So it's not surprising here. Again, squamous is a different disease, and it's important to see that this agent is active there as well. All right, so the next data set we're going to look at here, this is an important data set, and this is looking at sacituzumab govitecan plus pembrolizumab. Many of you may be familiar with sacituzumab govitecan. It's a TROP2-directed antibody-drug conjugate. It's approved in both breast cancer and bladder cancer, and it's being explored in metastatic non-small cell lung cancer. We're going to talk about a number of TROP2 ADCs today. So this is preliminary results from the EVOKE-2 study, and I think this is an ambitious approach that we're looking at with a number of agents, sacituzumab govitecan, as well as Dato-DXd in combination with immunotherapy and potentially even with chemotherapy, not on this trial, to get these TROP2 ADCs to our metastatic non-small cell lung cancer patients as soon as possible, potentially in the frontline setting. So let's see what we have here. So what we're seeing here is a waterfall plot, and this really emphasizes the activity of this combination. So we see two different patient populations: the PD-L1 high, shown in the dark green in the waterfall plot, and the PD-L1 low in the lighter green. And I would argue that we're seeing a similar benefit. I mean, certainly if we look at the waterfall plot and our eyes go all the way to the far right, we are seeing dark green for the first, let's see, six tumors. So yeah, that does emphasize what we would expect, that patients with high PD-L1 are more likely to respond to a combination that includes an anti-PD agent, similar to what we've been talking about with chemotherapy. But there still are plenty of patients with the light green that are having objective responses, which is below that dotted line, and even many on the right-hand side. So when we look at this in a different way in the table, looking at the objective response rate, again, higher in the patients with PD-L1 greater than 50%. This is not surprising at all to me. We would expect with pembrolizumab alone, the response rate to anti-PD agent being, in the low 40% range. In the less than 50s, we'd expect the number to be lower, but similar to my comments on a previous slide, lumping a 49% PD-L1 patient with a zero PD-L1 patient may be a bit misleading. So it'd be interesting to see this broken down a little more granular. But bottom line is we're seeing good activity with this combination, both in the high PD-L1 patients and the low to zero PD-L1 patients. Median duration of response not reached in both. Duration of response at 6 months, 88%. So looking pretty good. So in the total patient population, 61 patients. Again, I have to say that because caution where we're going with this is still a limited number of patients on, no, it's not a randomized trial, so single arm. In terms of no comparator, but a 56% objective response rate, suggesting that more than half the patients are having a response, with a response rate of close to 50% in the patients that had PD-L1 less than 50%. I think this is very interesting. So objective response rate is certainly an early indicator of if and how these therapies, moving these TROP2 ADCs into frontline, may be beneficial to patient. But as we think about it, and as we're adding agents, especially in the greater than 50% patient population, it's really going to be about overall survival. I mean, there's no really other way to put it. We're going to need to see if these patients are actually living longer. It's great to see that they're having a nice response rate, but we really need to see the overall survival in these patients. And that's because we know that we're adding some toxicity with the addition of the TROP2 ADC. So looking at the right-hand side of this in terms of safety, really important to take away from the right-hand side that the immune-mediated treatment-emergent adverse events really don't appear to be significantly higher in any like shocking way, I guess is what I would say, than what we'd see alone with pembrolizumab. We see some grade 3 or higher pneumonitis, which is certainly very concerning and problematic. But these are rates similar to what we see with pembrolizumab. So in terms of immune-related toxicities, again, based on this limited sample size, I think we can conclude that the addition of the TROP2 ADC didn't markedly increase the immune-related toxicities to a point where this might be an unsafe combination. Now we look at the left-hand side, and these are any grade treatment-emergent adverse events in greater than 15% of patients. Here's where we do see more toxicity, and that's not surprising, and I think it probably is acceptable level of toxicity. But we know that with pembrolizumab alone, a rate of diarrhea in more than 50% of patients would not be expected. Bone marrow suppression with anemia in almost 50% of patients, neutropenia, that would not be expected with pembrolizumab. So these are toxicities we know associated with the sacituzumab govitecan, including hair loss. And these are things that are going to matter to patients. Clearly, this approach has more toxicity than pembrolizumab alone, but especially in the patients that are less than 50%, pembrolizumab alone really isn't the appropriate comparator for us to be thinking in terms of a toxicity profile. It would be pembrolizumab plus chemotherapy. And within that lens, again, cross-trial comparison, all those problems, limited data set, doesn't matter. But if we're thinking about the data that's presented here, I'd say that the toxicity that's being presented here is reasonable and tolerable. I mean, I think that this is not so out of line with what we would see when we combine chemotherapy with pembrolizumab. And I think that this supports the idea that it's definitely worthwhile exploring TROP2 ADCs in the frontline setting in combination with immunotherapy. And I really firmly believe that it's all going to be about overall survival. And so, nothing in this safety profile to suggest we need to abort ship now, I guess is how I would take it. I'm encouraged and excited to see how this plays out over time. This was a World Lung abstract looking at a phase 2 trial of cerlasertib and durvalumab in advanced non-small cell lung cancer patients with and without RAS mutations. This is the results of Arm J of the NLMT trial. And you can see in the patients with KRAS positivity, a durable clinical benefit rate of 40%. And looks like an objective response rate of 13% compared to the no KRAS, where the numbers are lower. this data set's very small. I think this supports the idea that this drug may be effective in combination with patients with RAS mutations and clearly differentiates based on RAS mutation. But I think we need to see a lot more here to really move this as a potential forward. But again, subsets and identifying patients that maybe don't have as good a benefit with our traditional approaches, I think that's where this trial may have some legs. So this is the TROPION-Lung01 study. This is a data set that I'm very familiar with because I presented it at ESMO. And I think this is a very important data set to be talking about today. This is the first results that were presented of a randomized phase 3 study evaluating Dato-DXd, which is a TROP2 ADC, very similar to sacituzumab govitecan, which we talked about earlier, versus docetaxel in patients with previously treated advanced metastatic non-small cell lung cancer. So this is the study design. It was a very ambitious trial design. It was randomized phase 3 study. It was based on some early efficacy data showing an objective response rate around 26% in these patients. And you can see patients both with and without actionable genomic alterations were enrolled. Patients were enrolled irrespective of histology, and TROP2 expression level on the tumor cell surface was not required at any specific level for enrollment because TROP2 expression level has not appeared to correlate with Dato-DXd response. Patients without actionable genomic alterations must have received both chemotherapy and immunotherapy either together or in sequence. And those patients with actionable genomic alterations, the list you can see here, must have received targeted therapy followed by chemotherapy, and they can have received immunotherapy, but they didn't have to. These patients were then randomized 1-to-1, received Dato-DXd versus docetaxel. Important to note, and we'll go over both of them today, there were dual primary endpoints on trial, progression-free survival by blinded independent central review and overall survival. So this is progression-free survival in the intention to treat population. Again, this is the first of the two dual primary endpoints. And what we see here is a statistically significant improvement in progression-free survival in favor of Dato-DXd with a hazard ratio of 0.75. And this is supported by more than doubling in the objective response rate for the Dato-DXd treated patients compared to docetaxel and a longer duration response. But what I think was most important about this data set was that, this experiment or this trial did prove, was a positive trial and proved that Dato-DXd had improved progression-free survival over docetaxel. But when you look at the median progression-free survival difference, although the hazard ratio is 0.75 and it's statistically significant, when you look at the all-comer population, you see a progression-free survival benefit of, approximately 0.7 months, can we say that's clinically meaningful or significant? Probably not. But what's really important is when we looked at the histologic breakdown, what we saw was that the non-squamous patients are really the patients that are deriving the benefit with a hazard ratio of 0.63 compared to the squamous patients that really didn't have profound benefit at all from Dato-DXd. The patient population that actually drove the greatest benefit on trial were the patients with actionable genomic alterations. All but 3 of those patients had non-squamous histology, but their hazard ratio in favor of Dato-DXd for progression-free survival was 0.38. So very impressive. And, the question that arose was, is the non-squamous benefit we saw entirely driven with respect to progression-free survival by the actionable genomic alteration patients? And the answer is no. The hazard ratio for progression-free survival in favor of Dato-DXd in the patients with non-squamous disease that did not have actionable genomic alterations was 0.71. So, again, a positive trial, but I don't think a therapy, at least in unselected manner, for the squamous patients, more appropriate for the non-squamous patients. And this is the second of the two dual primary endpoints on trial. This is the interim overall survival analysis. There were 2 overall survival analyses planned on trial, this interim overall survival analysis that I presented, and then a final overall survival analysis that has not occurred, but will be presented at a future meeting. So in terms of the interim overall survival analysis, we see here there was a trend in favor of Dato-DXd, but it did not cross a pre-specified boundary for statistical significance at this time. However, again, we can see here that histologic divergence in terms of benefit, where the non-squamous hazard ratio for overall survival is 0.77, slightly over 1, but certainly more events needing to occur. And the squamous patients clearly are not benefiting from an overall survival or progression-free survival perspective with Dato-DXd with a hazard ratio greater than 1. So contextualizing this as a potential therapy for our non-squamous patients that are previously treated and eligible for docetaxel, I think is very reasonable. We don't have the overall safety summary in this presentation, but the rate of grade 3 or higher treatment-related adverse events was higher for the docetaxel arm at 41% compared to 25% for Dato-DXd. That's despite a longer duration of therapy for the Dato-DXd patients. And these adverse events of potential interest, I think, are important to understand. There are 4 categories here. And as this agent potentially enters the clinic in non-small cell lung cancer as well as potentially breast cancer, there was also a presidential symposium of TB01 suggesting that this is a potential new therapy for breast cancer patients. It's really important to understand these toxicities. So the first toxicity, which is an umbrella term of stomatitis and oral mucositis, that was the most common AESI experienced by patients treated with Dato-DXd at 54% of patients. But importantly, only 6% of these events were grade 3 or higher, and these events did not inhibit the investigator's ability to effectively deliver the drug, as less than 1% of these events led to dose discontinuation. We do know that ocular events do occur with Dato-DXd. They're typically low grade. However, they occur in about 20% of patients, grade 2 or lower, typically with increased dry eyes or increased tearing. So something to watch out and certainly refer to the ophthalmologist as appropriate. But again, typically not interfering with our ability to administer the therapy. Now, with other agents that have the DXd payload, such as T-DXd, we know that drug-related ILD does occur. And that's a specific toxicity we need to be concerned about in our lung cancer patients who already have disease in their lungs and oftentimes have smoking damage as well. So it's important to understand the ILD data from this trial. So 8% of patients had a drug-related ILD event associated with Dato-DXd that was adjudicated by an independent committee. 3% of those patients had grade 3 or higher events, and there were 7 patients that had a grade 5 Dato-DXd adjudicated ILD event. Within the context of those 7 patients, it's important to understand that 4 of those 7 patients, the investigator on site attributed the death primarily to disease progression, but the independent committee said this was a grade 5 Dato-DXd ILD event. And finally, infusion-related reactions do occur with Dato-DXd. They occurred about 8% of patients on either the Dato-DXd arm and the docetaxel arm. All of those events were grade 2 or lower, with the exception of 1 grade 3 or higher event. So, I mean, I think that there are new toxicities that we do need to be aware of and monitor for, but I don't think they're toxicities that are new to oncologists in general. There are toxicities such as mucositis and ocular events and ILD that we've dealt with before. And I think that this potentially does present a new opportunity for our patients with non-squamous metastatic non-small cell lung cancer in the second line or third line setting, both AGA and non-AGA patients who are eligible for docetaxel.
Was the study blinded?
No.
Well, I mean, you knew what people were getting. I mean,
Yeah.
did you have any? So, I would imagine then. I don't know. I guess you've seen. How many people do you think you've seen receive data?
I know that. So we've treated more than 60 patients with Dato-DXd across tumor types at UCLA.
That's what I was going to say. Yeah, that's what I was going to say. You probably have by far the greatest experience. So,
Yeah.
I'm very curious to ask you. So, a few things. What about the need for dose interruption or dose reduction?
Yeah.
Was that the same or different?
So the need for dose reduction, it was in the ESMO presentation. It was more common in the docetaxel arm. But the need for dose interruption was more common in the Dato-DXd arm. And, I think that discontinuation, we didn't talk about this, but discontinuation was higher in the docetaxel arm. My experience with this drug has been very good, but dose delay, interruption, and potential reduction has been warranted in some cases. And I'd say that when it's been used, especially for like the mucositis, which is occurring in about 50%, a little over 50% of patients, it's been very effective. And my personal experience has been that if, this is oftentimes happening in patients that are benefiting from therapy. And obviously, there's a lot more science that needs to go into it, and there's a lot more than just one individual's site that needs to answer these questions. But when we've seen patients who have done well for an extended period of time on this agent and then required a dose interruption or then subsequently a dose reduction, I have not seen a temporal relationship between that dose reduction or interruption and loss of control of the disease, to me suggesting that these things are safe. If you look back at the phase one data, the dose that's being used here is 6 milligrams per kilogram. If you look back at the phase one data, 4 milligrams per kilogram, which is the dose we would reduce to initially, has a lot of good data. So I think that, as we move forward, especially with patients that are going to be on this potentially for a long time. I have many patients been on for several years. We definitely need to be thinking about quality of life, and we definitely need to be aggressively considering interruption or reductions when possible. Because again, I think that it would be great to see some more concrete data across the study, but I think that those things are reasonable to do to improve patients' quality of life and potentially allow them to stay on therapy longer with benefit.
Globally, these people seem less sick from the treatment than docetaxel patients.
Yeah, absolutely. And I think that that's a really important question. And obviously, I can just give my opinion on it based on our extensive experience. But ultimately, I think everybody's going to certainly have to have their own experience with the drug. But I think that without question, unequivocally, in my experience, this drug is better tolerated and affords a better quality of life than docetaxel. There's no question. And as I kind of mentioned in passing as I was discussing, we had patients on the phase one trial. I had a patient who was on more than 3 years, and that's a long time to be on a drug. And I think that the tolerability of the drug is emphasized by the fact that somebody like that is on for that period of time. And what was her life like? Her life was very good. She had very few toxicities. She had an episode of mucositis about 18 months in, which we then dose reduced for. And as I said, she was on for several more years.
This is the first time anybody talked about eye toxicity when the toxin is DXD.
I appreciate you bringing that up. It's something that we have seen with some frequency at UCLA. And the preclinical data in mice did show some corneal toxicity, which is something we've seen with other ADCs. And so we were looking out for it. And I would say that clinically, it's somewhat of a nuisance, but not a huge issue for patients in general. I would say, as the slide suggests, it's some increased hearing, it's some dry eyes. It's nagging. Again, only 1 in 5 patients approximately are having it. But it can be more significant. And I would say that you can see here there were, 2% of patients with grade 3 or higher. And we have seen that. I mean, again, treating more than 60 patients, you do see some of the bad outcomes. And that can be in the form of keratitis, corneal toxicity. Now, the trials are very strict in terms of where they're written. So I would say in terms of how it's most problematic, to be honest, once we've been able to better understand it, we've been much more able to identify it early and manage it appropriately so it doesn't get to the bad toxicities. But the trials have been written so stringently, appropriately. I'm not criticizing this anyway, but a grade 2 ocular toxicity has required us to hold the drug until grade 1 or less, which is a pretty low bar. I mean, our standard of care is docetaxel. And if the trial was reversed and Dato-DXd was the standard of care and we ran this, no one would say that docetaxel is a better drug. I mean, when you look across the metrics in the non-squamous population, they all are clearly in favor of Dato-DXd. I think that, stepping outside of the data and everything like that, I think that's, and I'm obviously significantly influenced by what I've already told you, that I've treated more than 60 patients with this agent, right? And that's why I treated, and it wasn't just me, it's my team at UCLA, right? I've had a lot of support from my colleagues, Jonathan Goldman, Eddie Guerin. And we would not be so excited about putting so many patients on this agent over docetaxel, and since we already know what docetaxel is, right, over such a long period of time, if we didn't think this was better. So I think that from both an efficacy and safety perspective, our personal experience has been, one of success. And, I think that if the intention to treat population analysis was not positive, then I think that we would be having a different discussion. Then I think that, the trial was designed to answer a specific question. And if it failed to show that in a positive manner, I think that the idea that then you'd look at a subset and potentially get an approval based on that, I don't think that's appropriate. But the trial was positive, and it showed that Dato-DXd from a progression-free survival benefit is superior to docetaxel. But again, I don't think anybody wants to pin their flag on that and say, oh, and somehow squint that zero point 0.7 months is meaningful. No, I think that we can clearly say two things. One, that the squamous population is not benefiting, which I think is important. It's an important negative outcome that will, I believe it should spur on the development of this drug with biomarkers. Within our subset of patients that have been evaluated, I have treated squamous patients and I have seen benefit. I had a patient on for almost 2 years. Now, again, the data suggests that in an unselected patient population, we shouldn't be doing that. So we can say definitively that. And in the non-squamous population, again, underneath the header of this being a positive trial, in the non-squamous population, the hazard ratio is 0.63. Median progression-free survival benefit is 1.9 months. And we've got an overall survival trend. We'll see the overall survival analysis. I think that the objective response rate is almost 3 times higher in the non-squamous population than docetaxel. The numbers are adding up. And I think that the overall toxicity favors Dato-DXd. So I guess, again, from a personal perspective, this is the drug I would choose if it was on the shelf now for my non-squamous patients. And, we'll see how it plays out, but I'm hopeful we don't have to delay that opportunity for our patients for several years by another trial. If it plays out that way, it plays out that way. But I guess, that's personal. I'm definitely, again, influenced by my own experience. No question about it. So here's another evaluation of Dato-DXd. This is the TROPION-Lung04 study looking at Dato-DXd plus durvalumab plus or minus carboplatin. So again, similar to the study we talked about earlier with sacituzumab govitecan plus pembrolizumab. There's also the TROPION-Lung02 study, which is looking at Dato-DXd plus pembrolizumab plus or minus chemotherapy. So again, looking at moving these TROP2 ADCs into the frontline setting. So they're a bit of a complicated study design. These were patients that got Dato-DXd plus durvalumab, and then at the 6 milligrams per kilogram dose, or Dato-DXd plus durvalumab plus platinum-based agent, which was carboplatin, at our standard approach for 4 cycles. And again, it's important to look at the toxicities. I think, as we talked about with the EVOKE-2 study combining a TROP2 ADC with immunotherapy, the overall takeaway here for me is that this is a tolerable approach and, on par within the bounds of realisticness with combining immunotherapy with chemotherapy alone. So what are the toxicities to really be thinking about? On the left-hand side, we see the doublet. We see a lot less bone marrow toxicity. That's what we're seeing in red, boxes in the red, which we see more on the triplet, which again, we're using a platinum agent. So, that is a differentiator here with Dato-DXd versus sacituzumab govitecan. When we look at the data for Dato-DXd, they're in combination with pembrolizumab here or on the TROPION-Lung01 study, which I just discussed, or many of the other studies, we're not seeing bone marrow suppression, which is something we do see with sacituzumab govitecan. So as we're thinking about different combination strategies, using an agent like Dato-DXd that does not on its own have bone marrow suppression in combination with chemotherapy seems to be one that may be a more successful strategy. So here's the general toxicity profile. Again, won't belabor it too much. Again, we see stomatitis, which was the toxicity we're talking about a lot with TL1. And as we were talking about, dry eye is listed here. Again, surprisingly, it's more common in the doublet arm than the triplet arm. I think this is probably an artifact of the trial. These are 19 patients versus 14 patients. There's nothing protective about carboplatin with respect to the eye. But the 26% rate is similar to what we saw in TL1 at 19%. Again, we need to see a lot more patients. So let's look at the efficacy. So the doublet, just combining the durvalumab plus Dato-DXd, you're seeing a response rate of 50%. When you add in the carboplatin, you see that rate increase. These numbers are good. The real question you need to be asking here is, how does this break down by PD-L1 status? We don't have that, but these are limited numbers. And we've seen on the TROPION-Lung02 study, which is evaluating pembro in a very similar setting in combination with Dato-DXd plus or minus chemotherapy, that across different PD-L1 status, we're seeing benefit, and even in the less than 50% and the negatives in the doublet as well. So I think the bottom line is that it does seem like a reasonable approach to be looking at these TROP2 ADCs in the frontline setting. The toxicity profile appears to be tolerable, and we're just going to have to see how the data plays out. But again, I think the concept makes sense. We want to get our best therapy to our patients as soon as possible, but the metric of success, ultimately, in my opinion, is going to be overall survival. So it's going to take some time to see how that plays out. So this is looking at the prognostic value of patient-reported outcomes and clinical and demographic variables in the Caspian study. So this is looking at these outcomes in our patients with the extensive stage small cell, where we do know that the frontline approaches are a combination of chemotherapy plus an anti-PD agent, either durvalumab or atezolizumab, typically. And so I think what's most exciting, similar to what we've seen in the non-small cell lung cancer population, is the tail of these curves. Now, the median overall survival with the addition of durvalumab to etoposide platinum is modest, but there at 12.9 months compared to 10.4. But I think what's exciting, and we see this in our clinic in a subset of patients, is the 3-year survival. 17.6% in the patients that got durva in addition to chemo versus 5.8% in the chemo alone patients. This is meaningful, I think, in our small cell patients. I mean, these are patients that are very sick. Oftentimes, they don't even make it to our clinic. They're so sick. And after frontline approaches, there really aren't a lot of great options. And I've seen some of these patients. I've had patients who transition on to durvalumab monotherapy and can live really good quality of life for several years. Almost 20% of patients. I think that's a really meaningful improvement in our ability to manage these patients. And that's where the quality of life analysis, I think, comes in, especially in these patients who are on a longer period of time. And so I think what we can take away here is that, patients who are living longer on those immunotherapy approaches are still having a very good quality of life. Again, we remember that the chemotherapy drops after, the first several cycles, and we're moving to immunotherapy alone. So it's very akin to what we're doing in non-small cell lung cancer. And single agent immunotherapy, durvalumab, is very well tolerated. And I think patients can have a very normal quality of life. And so I think that's basically what this slide set is giving us.
I was just going to say, I think what you just said is very valuable. I've often wondered, obviously when those trials came out, we talked about it, and, people thought about it and they ended up adopting it. And I always wondered, how much did it really, because the numbers aren't that, overwhelming.
Yeah.
And just the fact that, you feel like you observe in your own practice people living, not forever, but living longer with good quality of life, that's very valuable, very, very valuable to know.
Yeah, I absolutely think that, and that's what that's what the number here means. We see so many numbers, and we've seen so many numbers today, but I appreciate you pointing that out. I mean, these are not the majority of patients, no question about it. But approaching 1 in 5 patients with extensive stage small cell living to 3 years, that's meaningful. And when I've seen that, it's been patients, as I said. The majority of those patients have been patients that have clearly benefited from the immunotherapy approach, and oftentimes are on immunotherapy alone. And that's a good life. I mean, I can think of one patient. He's, he was not the healthiest person when he came into my clinic. He is definitely an older individual, but he had extensive stage small cell and looked like, for lack of a better way of saying this, one of my non-small cell patients who is doing well on, Pembro, like a PD-L1 high patient, who comes in for his fusion every 3 weeks and goes and lives his life and goes fishing with his family and things like that. I mean, in the setting of small cell, that's rare. And that's not something I think I haven't seen that achieved with other approaches. So yeah, I appreciate you pointing that out. And I think it is meaningful. Along the line of small cell, this is another agent that I think does have some real potential in the disease. And this is another DXD payload ADC. This is IDXD. And this is a subset looking at patients with refractory small cell, looking at a subgroup from the phase 1 and 2 study. This is the makeup of the IDXD ADC. We didn't look at this for some of our other talks when we were looking at Dato-DXD, but the deruxtecan, the DXD payload is the same for these agents. We've got this cleavable tetrapeptide based linker, and then the IDXD is targeting B7H3. There's a lot of information here I don't think we need to spend more time on. This was the study design, looking at patients with, across solid tumors, essentially. But then focusing really on the small cell cohort for this data set. And it's a limited data set, but this is encouraging. And, we're seeing in the waterfall plot 21 patients, an objective response rate of 52%. Again, my experience, obviously, haven't been in the field a super long time. But my experience is oftentimes on these, these data sets with limited patient numbers, the objective response rates can be a little higher than what ends up playing out. So certainly, do I think this agent's going to have a response in more than 50% of patients with small cell? I mean, I would be surprised if that occurred. It'd be amazing. But to start the high water mark there, I think is great. In our second line setting, if you look at NCCN for extensive stage small cell, there are so many agents listed there. And I think the reason so many agents are listed there is because none of them work great and they're toxic. When we say that, one of the agents that we often use is topotecan. And an important point here is that the DXD payload is a topo1 inhibitor. So there's a bit of a connection in the small cell story. And, what are we seeing? Median PFS 5.6 months in these small cell patients, median OS 12.2 months. I mean, that median overall survival on this trial is better than what we saw in the frontline patients on the Caspian study, right? I mean, I'm not cross-trial comparing, but I'm saying that, the median overall survival in these 21 patients treated with IDXD after progression on prior frontline therapy is another year. I think these numbers will come down over time. But I think this agent is definitely showing activity in small cell. And I think it definitely warrants additional evaluation. And I would love to see with this agent or some of the others that are coming up, I would love to see the second line space become more clear. Because as I said, when you look at NCCN and you have basically 10 options and no clear, this is what we do, it basically tells you all you need to know. So maybe this is an agent that will give us a more clear story. I think obviously needs to be evaluated in a much larger patient population in a randomized fashion. I can make that statement about a lot of therapies. In terms of the toxicities, even though we have the DXD payload in a number of agents, TDXD we've talked about today, Dato-DXD we've talked about, there's a HER3-DXD, the toxicities are different. And I think that likely is a result of where the target is expressed. And so we are seeing, as opposed to Dato-DXD, we are seeing some bone marrow toxicity here. It's not significant. It's nausea, which is the second most common toxicity with Dato-DXD, some fatigue, anemia. But when we look over on the right-hand side, grade 3 or higher events, there's not much there. There's a couple single events in a number of categories. Again, really small patient population. And we are seeing ILD here too. So this is something to be watching for with all our DXD molecules. But certainly not a molecule that is stepping well outside the bounds of what we've seen with our other DXD molecules, and one that I certainly think in our second line setting for small cell is something that we would consider this toxicity profile tolerable, especially with efficacy even similar, even if not quite what we saw on the last slide, but even similar to that. I think that'd be very exciting to the field. So we're going to wrap up our discussion today with another exciting agent in small cell, tarlatamab, for patients with previously treated small cell lung cancer. This is a bispecific antibody that targets DLL3 as well as CD3. What we're seeing here, again, is some impressive, single arm at 2 different doses, objective response rates of 40% and 31.8%. Median overall survivals at the bottom in the 10 milligrams of 14.3 months compared to non-evaluable. And this is meaningful. I think that we are seeing some of these bispecifics that are immunogenic go into other disease types. I'm not as familiar with that. Maybe Dr. Love, you'll comment on that. But the toxicity that we're not as familiar with in lung cancer community is the immune-mediated toxicities such as cytokine release syndrome that occurred in more than half of patients with this agent. So does that preclude the ability for this drug to make the clinic? I don't think so, especially if the path is going to be paved with other agents in the community and the ability to manage these toxicities. I think cytokine release syndrome is a very concerning thing, but I think that it's something that is often, I think that we're learning more about how to manage it. And I really do think, with the IDXD data we talked about in this bispecific here, we really are in desperate need of additional therapies for our patients with extensive stage small cell after progression on the standard of care chemoimmunotherapy. And I think that even with that rate of cytokine release syndrome in more than half of patients, I think that effective management of that and being able to deliver these kind of benefits to patients, if this plays out over time in a randomized fashion, I think that these are potential real game changers in small cell. And I think that's very exciting.
Yeah, no, I was just going to say that, in terms of cytokine release syndrome, I mean, it's here in our neighborhood right now. myeloma, lymphoma, follicular lymphoma, diffuse large B cell. These CD3 immune bispecifics are approved. Right now, they're getting used mainly in tertiary centers. They actually have to start out there, but some of them are very, very well tolerated, very efficacious. So they've already, by the time it looks like maybe something like this gets out there, they have a lot of experience with this. And the only thing is, it is important. You know, you think of somebody with small cell, maybe they have recurrence, they're lost a lot of weight, now they're getting their blood pressure is going to drop, or I
Yeah.
don't know. That may be different than a 26-year-old lymphoma patient. I don't know. But all I'm saying is one thing for sure is oncologists are already learning about it right now.
Yeah, I think that's incredibly important. And I think that having the structure in place as these agents move forward will be great for our patients. But I think your point is also key. Each patient population is different. Small cell lung cancer patients are oftentimes very sick. And so we will have to see how these toxicities play out in this patient population. However, if they can be managed, especially where most patients are treated in the community, I think that anything that can deliver on improving our second line space in small cell is something that we should dedicate our resources and time to, because small cell remains a very aggressive, very rapidly progressing disease, and we do need new opportunities and agents for that.